I am here today to talk to you about how palliative care removes suffering and distress at the end of life, and why doctors believe that good palliative care is the answer and not assisted suicide. My name is Dr. Pauline Kane. I am a palliative medicine consultant, and on a daily basis I deal with and support people who have a myriad of conditions. Half of the people I see have cancer, the other half have things like heart failure, MS, motor neuron disease, emphysema, diabetes, and these are people whose worlds have been turned upside down. In palliative care, we understand and we recognise that to get a diagnosis of a terminal condition, it can be absolutely terrifying. It's a very lonely place to be. Your world is turned upside down. You lose your identity, you may lose your job, you may have financial concerns, you may have a lot of physical distressing symptoms, pain, shortness of breath, anxiety. Perhaps you were the person in your house who was the breadwinner, you supported everybody else, that now has been turned back to front, and now you are dependent on others, and this can be very distressing. I work with a team of palliative care nurses, social work, physiotherapy and others, so we can support people along this journey and look at what is concerning them, what is troubling them, and what can we do to really show them that they're actually still alive. In the midst of all of this, they may feel completely lost. Often I say to people, you're actually still alive, and our goal is to improve your quality of life as much as we can for as long as we can. As Cicely Saunders, one of the great beginners of what we would call the modern palliative care movement, she said, so that people can live until they die. And really that's what we're about in palliative care, to improve the person's quality of life while they're alive, and then at the end to ensure that they have a comfortable, peaceful death. We're very lucky in modern day medicine, palliative care. I have an armoury of drugs that I can call upon that manages any symptom that a person is going to experience. One of the concerns that people often mention as supporting assisted suicide is unbearable pain, that they're worried about the unbearable pain they're going to suffer. I suppose by case of example, recently I had a young adult and she had been diagnosed with a tumour in her leg. This is a tumour that's very fast growing, and in your leg it's a small confined space, and this tumour is growing really, really, really fast, and it can cause the most horrible pain if it is not addressed properly. When she was referred to me, she already had been diagnosed a few months previously, and when I went to see her, she was upstairs in bed in a darkened room. Her back was turned to me. She told me to go away. She didn't want anything to do with me. She didn't think I could help her. But I said to her, give me a week. Just give me 1 week. And let's see, can we get you downstairs? Can we get you back? Meeting her boyfriend, she didn't want to see him, talking to her family. So she agreed she would give me 1 week. At the end of that week, myself, my nurses, we worked with her. We had her downstairs. Yes, we had her on a cocktail of strong pain medication, but she was downstairs, she was getting takeaways with her boyfriend, she was living again. But our job was not finished there because her tumour was growing quickly all the time. So our input was quite intense. We were with her often on a daily basis at home, and we had continually adjusted her pain medication. By the end, she ended up on the equivalent of thousands of milligrams of morphine type medication, but she was functioning, she was happy, and she was comfortable. She was worried about the end. What would it be like? Would she be in pain? But more, would she be distressed? So we said, no, we will be there, and we have the drugs available to us to make sure you will be fine. And she was fine. She died surrounded by her boyfriend, her mum and her dad, and she slipped away peacefully. And we are fortunate now that we have the drugs available to us, that the deaths of years ago that people describe are no longer an issue. I can remember my father coming home having seen a work colleague who had lung cancer and saying how the man was roaring out in agony, and he was so distressed by what he had seen. And I often think that now that wouldn't have happened. Another thing that people will say to me often, that they're worried about having a slow, drawn out death, and what is the point, how to exist like that. And this is particularly for people with non-cancer conditions, and I suppose particularly in the setting of heart failure. I remember a patient of mine, and his dad had heart failure, and obviously it was a hereditary condition, and he had seen how his father had died this slow, agonizing death where he was short of breath, he was distressed, he was uncomfortable. And I reassured him that no, we had the drugs, we had the nurses, we had the psychological support to walk him through this. And we did, as be it the shortness of breath, the pain, the anxiety. We gave him the medication he needed, and we gave him the psychological support he needed, and that man had a comfortable, peaceful death, surrounded by his family. Another situation that people worry about, about dying in pain and without dignity. And I can distinctly remember when I started in palliative care, meeting this lady, her son had a brain tumour, and she described to me the death her husband had had, and it sounded horrible. It was really horrible. But it was before we had the drugs we have now. And we could reassure her, and it was so rewarding to be able to say to her, well, no, that is in the past, and now your son will have an entirely different experience, which he did. Because we are lucky in palliative care to have access to these medications, these drugs, and to have access to a team of specialists who address not just the physical symptoms, but the psychological distress, the social burdens, and the spiritual distress that people can experience. Often when people will be referred to me, they've had the terminal diagnosis, they're distressed, they may have a lot of physical symptoms, they're in a very bad place, and they just want to die. They're afraid, they're fearful, they feel a burden to their family. And so in palliative care, I work with a team of people, and we can give them the support to talk through those fears, to address that physical distress, that psychological distress, and to put in the supports at home so they no longer feel a burden to their families. Talking to colleagues internationally where assisted suicide is available, they would say to me that once a person says they want to die, they automatically get referred for assisted suicide, and all those conversations are shut down. There's no longer the opportunity to discuss their fears, to discuss their distress, their psychological distress, why are they distressed, to discuss the burden and to see can that be addressed. So these people die in fear, in distress, and feeling as they're a burden to their family. To me, that is not dying with dignity. Dying with dignity is having access to good palliative care. Because if you have good palliative care, you are not going to die in fear, and you are not going to die in distress, and you are not going to die as a burden, because we want to make sure, as the palliative care team, that that is not the situation. The problem we have in this country is that the funding for palliative care is very poor. Really, we get the sense from the government that they don't really understand the service that we deliver. We need what we call multidisciplinary teams, so that I have access to nurses, physiotherapists, occupational therapist, speech therapist, dietitian, the gamut of people, that we can support a person's every need, social work, that every need can be looked at, because when you have a terminal diagnosis, it doesn't just affect you, it affects your family. And it's being able to walk with those people so that their issues, their worries can be addressed, and then that we can support them to have a comfortable and peaceful death. So really, I would be saying to the government that no, the emphasis should not be on assisted suicide. That is not the answer. The answer is good palliative care for everyone in this country.